I'm going to talk about the effects of prior experience with medication on the development and the size of placebo effects, again in chronic pain patients. And you've already heard that there are three mechanisms in placebo analgesia. That's classical conditioning, expectation, and social learning. And most of the studies so far that have been conducted for placebo analgesia have been done in healthy subjects. And I think, or we all think, it's very important to transfer this knowledge to patients. And why is understanding the placebo effect in patients so important? Because all drugs that we have a pharmacological component, and Regina already mentioned the open-hidden paradigm, where in the hidden condition where the subject or the patient doesn't know that he is getting a drug, we have the pharmacological effect of the drug, but in the open condition where there's the additional support by the doctor or the nurse, we have the psychological effect. And in many drugs, the psychological effect doubles the pain-relieving effect of the hidden injection. So that's why it is so important, because we can help patients better if we maximize the psychological effect of the drug. And just one other point I'd like to make here is that patients are different from healthy controls. And that is especially important in placebo analgesia, because they come with a learning history in regard to pain. If they're chronic pain patients, they will have got many pain medication and pain treatments, so they have either positive or negative pre-experience. They have pre-expectations that they come into the lab with or into the doctor. The current context of them is different because the meaning of pain is different for them than it is for healthy controls. And it goes on, and all of these factors, all of these contextual factors then contribute to the placebo effect, which consists of the pharmacological and the psychological effect. So what we did, and that's a similar study to what Regina already showed you, so I'm going to go into very briefly over it. We took 49 chronic pain patients from an outpatient clinic, and we divided them into two groups. So what we were basically very much interested in how verbal instruction could elicit placebo effects. So all of our patients got the verbal instruction that they would receive a very potent painkiller, even though it was just saline. And half of the group additionally underwent a conditioning procedure. So what we did is we gave them pressure pain stimuli before at a certain fixed intensity. Then we administered the placebo in the same way that Regina already explained, with a plaster on the back in which we infused the injection. Then we did an intervention run where the verbal instruction group basically got the same pain intensity again, whereas in the conditioned group, we reduced the pain intensity. And then we have the post-treatment group where we did exactly the same as in the baseline. And of course, in all of these placebo researches, you should have non-treatment groups where you basically don't give the placebo, but everything else is the same. So here, instead of the placebo, we just had a 5-minute wait time for the subjects. And just to remind you, the placebo effect that I'm going to talk about is always the comparison between baseline and the post-treatment, because that is where the stimulation was basically the same. So what did we see? First of all, we have our two groups. That's the verbal instruction and the classical conditioning, as well as the verbal instruction alone and the natural history. And we can see that for experimentally induced pressure pain, we see a relatively large placebo effect in both groups. And also that there was no difference between the two groups. So the verbal instruction was so strong that an additional classical conditioning procedure apparently did not work. So this is the experimental pain that we delivered to the patient. But now that we examine patients, we also have the opportunity to look at their chronic pain and see what happens there. And you can see something similar. You can see a large reduction of pain of about 20% after the placebo in both groups, whereas in the natural history you don't see any effect. But you don't see an additional benefit of the conditioning procedure. And now that we have two kind of placebo effects in patients, we can see how these two are related. So what we did here, we looked at the placebo response to experimentally induced pain in subjects and the one to their chronic pain, and we just correlated them to see if there is a relationship between the two. And to our surprise, what we saw is that there is actually no relationship between the two. So you can be a responder on experimental pain and a non-responder to chronic pain, and the other way around. So these two placebo responses in patients are not related, which is something very interesting, I think, if we try to take the results we get from healthy subjects, where we always use experimental pain, and kind of like try to transfer it to patients. So I said that I also want to talk about experience patients had with prior treatment. And all of these patients were of an outpatient clinic that had a long history of pain already, and obviously their prior experience with pain medication was negative, because if it would have worked, they wouldn't be there in the clinic anymore, so they all still had ongoing pain. And how we measured is that we did an interview with them where we asked them what specific medication they took and whether it was positive or negative, whether it alleviated their pain or it didn't. And then we again correlated it with the placebo effect. And what we see here is that patients that had a very negative treatment history, which is here, and positive treatment history is up here, the one with a negative treatment history had a larger placebo effect than the one with a positive treatment history. And we believe that's the case because our verbal instruction, again, was so powerful that it overruled all of the negative experiences they had with their treatment history. And because our doctor-patient or therapist-patient relationship was very strong, and we spent a lot of time on working with them in this study. And this slide also, that just shows that there are a lot of functional networks involved in placebo analgesia, and that the three mechanisms we have actually look at or involve different areas in the brain. And we did this study similarly, again, in the fMRI with subjects with chronic back pain. And this is a bit full, but the design is basically the same that I already explained to you. We took chronic back pain patient, only in this study we also took healthy controls, and we again divided them into two groups. All received the verbal instruction of a very powerful, potent painkiller, and another group additionally underwent the placebo conditioning. We did electrical stimulation in the fMRI, and we measured the neuronal responses before placebo and again after the placebo, and the difference between the two is the placebo effect. And we also had a natural non-treatment history again of 14 patients that didn't have the placebo but just a wait time. Okay, and these are our results. So this is the group of the chronic back pain patients, and the one in green are the one with just the verbal instruction. And I'm just saying just because there's nothing just about it. It's very, very strong, the verbal instruction. And the blue group is the one that additionally received the conditioning. And you can see that we see a significant reduction in experimental pain in the patients with chronic back pain. We also see a significant reduction in the healthy controls, and we see a slight significant reduction in the natural history, which is probably habituation to the electrical stimuli. But the difference between the two experimental groups, the chronic back pain and healthy controls, was significant towards the natural history, so the effect they had was larger. But as in the earlier study we showed, and in the study that Regina showed, we see no additional effect of the conditioning, probably because our verbal instruction was so strong. And these are the results for the chronic pain. Obviously, that's only possible in the chronic back pain patient because you would see 0 in the healthy controls. But you can also see that with both groups, again, we have a significant reduction in their chronic back pain compared to the natural history, who show no difference at all. And Regina also mentioned it, and what we did is we told them not only would their chronic back pain and the experimental pain be reduced by the placebo that we gave, but also that the functional capacity would be improved. And Regina already showed a nice picture of the video of the patient where they performed different activities of daily living, and we taped them, we measured the time it took them, we asked them how much pain they had while performing these activities. And we did that as well. And here you can see, this is the placebo group, the dark one, and you can see a significant reduction to the post group. Whereas in the natural history, you don't see any difference of the interference of the chronic back pain with the activity. So again, for chronic back pain patients, we now have 3 placebo effects, basically, on the experimental pain, on the chronic pain, and also on functional capacity, which I think is very nice because chronic back pain patients that come to the clinician, they do complain about their chronic back pain, but they have a whole bunch of other problems that are related to the chronic back pain. And this kind of like captures it very well if you do these kind of experiments, these kind of tasks with them. So as I mentioned earlier, we did this study in the scanner, and here I'm going to show you what happened when you look at the brain responses. So this is the pain activation before the placebo in patient and in healthy controls, and what we mainly see there is insular NS2 activity. We don't see very much of the ACC or other emotional components, probably because electrical pain is very artificial. This is the pain activation after placebo in patients and in healthy controls. I'm just going to show this because in patients, I'm just going to show this to show you basically that we still have activation going on after the placebo, but the interesting comparison is of course what happens before and after placebo, and you can see that here, which is what we kind of like dubbed the placebo effect. And for patients, we saw higher activation in the rostral anterior cingulate cortex and the amygdala when we compare them to healthy controls. And the contrast in the other direction is we see more activation in the medial frontal gyrus in healthy controls than in patients. So the results we see for our patients are actually quite similar that we see to healthy controls, for example, studies by Ulrike Bingel, whereas in our placebo paradigm, the healthy controls had more activation in areas that are more involved in cognition, whereas our patients had more activation in areas that are more involved in emotional aspects of pain, which I think captures very well the relevance of the chronic back pain patient for the emotion, pain for the chronic back pain patient, and that the pain they have is very much emotional. And now what we did is we looked whether the behavioral placebo response that we measured correlated with brain activation. And what we could see here for patients, that we have a negative correlation in the ACC, and it's again the rostral ACC. So that means the higher the placebo response, because if you remember, we define placebo response as the more negative we get, the bigger the placebo response. So the higher the placebo response, the more activation we have in the ACC after the intervention compared to before the intervention. And for healthy controls, we have a positive correlation with the hippocampus and S1, which also fits very nicely. So to sum up, what we see in chronic back pain patients is a reduction of experimental pain and also reductions in chronic pain, and there are only very few studies on patients available. Most of the research is done in healthy controls. We see no additional effect of our conditioning, and we believe that this is due to the very strong verbal instruction that we give and the relevance the drug that we're giving has to the patients. There's no relationship between the two placebo effects that we see, so the experimental one and the chronic one, and we think that might be due to different mechanisms. So we know that there is the opioid mechanism of placebo analgesia, there is a more prefrontal one, and then there's also the involvement of cannabinoids. So maybe these different systems differentially affect the two placebo effects we have. And we see an involvement of the rostral anterior cingulate cortex and the amygdala for patients, and more frontal areas for control subjects. And to end with, I'd just like to reiterate what Regina already said. The take-home message for the clinical applications of the analgesic placebo effect is not that you should give placebos to patients and not tell them about it. It is that you give the medication as openly as possible to maximize the psychological effects of expectation, and also you can maximize the effects of conditioning. Don't overestimate the effects to the patient. If you talk to a chronic back pain patient and you tell them, okay, this drug will completely reduce your pain, you will be pain-free afterwards, that's a little bit unrealistic. Take your time to ask patients about their previous experiences and their previous negative aspect with the pain medication. And if they have previous negative experience, that doesn't mean you can't do anything. Actually, as we showed, if you take these patients and you spend a little bit more time with them and explain with them the mechanisms of their drug and what they can do with it, you're very open, then you can actually have a bigger effect in these patients than in the other ones. And lastly, in inpatient healthcare, it's the same thing. Give the medication as openly as possible, structure the context in which the medication is given so that associations are formed between context and the taking of the medication. Emphasize the relevant information and label the medication. I mean, most of us know that when you go to a hospital, you get your little dispensers of the pills, and there's actually nothing on there. It's just a green pill and a blue pill and a white pill, and you don't know what's that all about. And with the last slide, I'd like to thank the people that were involved with it and our funding agency, and thank you for your attention.